Good evening, everyone in US and Americas, and evening or late evening to those in Europe, early morning to those in the Middle East, and early morning, well, not that early, to those in Australia and the rest of Asia. Now, today is a little different. We had a little bit of shuffling amongst the hosts and faculty of Virtual Spine, and I've actually recorded this in advance because I couldn't be in two places at once at the start of the meeting. So hopefully this works. We're just going to give a little recording session of my talk first, and then I will be online to take questions afterwards. So if you do have any questions during the meeting, try to put them in the chat box and we can take notes and answer them. Some of the other faculty may be on, and so we'll step in and hopefully help me out a bit here. Today, I'm going to be talking on neuromodulation. For those who know me from this meeting and other places, I do a fair bit of huge spine deformity work and a lot of implants and other things, but of course that's not for every patient. And I do have a reasonable amount of experience now in the neuromodulation space with a variety of devices. So I was going to talk a little bit about some of that today, and I'll just get this presentation going. As I said, please feel free to, at any time, ask some questions, but I will be live and in person after this presentation, so hopefully that should work. All right, so this is some work that I've been doing for a while now. I first came across a device called the Reactivate device for chronic lower back pain about 4.5 years ago, when some reasonable trial data, albeit company sponsored, came out, and the device was approved for use in Australia. I was asked to comment on it on our national news, and had to then go and look at the data so I didn't sound like a goose on TV. It actually seemed pretty good, despite the inherent biases of company data. I thought there may be something to this device, and it might help a population of patients that I wasn't really able to help previously. So I've done this work through one of my clinics at International Spine Centre here in Adelaide, South Australia, and also the 3D research arm of that. I've had help from Dr. Y.H. Yao, who has talked a little bit about this on this meeting before, Professor Whittle, and our fellow, Dr. Carlos Lijo as well. So I'd like to acknowledge their work, as well as the team at Mainstay Medical. So this is what I do spend a lot of my life doing, huge operations. And of course, this patient had long-standing scoliosis and back pain, but you know, they have a spine deformity, and we know that fatigue-related pain in these patients often does improve, but major surgery can be required. And this is, of course, not for everyone. This patient has had a good overall result, restoration of alignment, and been very happy with their surgery at 2 years post-operatively. For lesser problems, we can consider things like fusion and even TDR. I don't do a lot of TDR. The number one indication for me is above a spondylolisthesis, where the disc has become degenerate and you wish to try to retain some motion. And this is a recent case of lumbar TDR that I was able to do with my colleague, Dr. Matthew Rackham. As I mentioned, I don't do a lot. I'm very, very selective with the use of both TDR and ALIF for degenerative disc-related back pain. You know, this patient also had a spondy's, had a good indication for surgery at 5-1 in particular. But, you know, the question often in these patients is, do you leave 4-5, include it in the fusion, or provide motion preservation? And to me, this is a nice option. But again, really very selective with when, where I can do this. So there is a problem that no one's really addressing, and that is that the multifidus is weak. The multifidus muscle is an issue in a number of our patients with chronic lower back pain. And when we look at an MRI, we're often looking at the disc, the bones, the structures around it. But we tend to focus really on things like neurological compression, disc degeneration, bones, bony lesions, facet arthropathy. But when you look at your lumbar MRI, you can see the posterior spinal musculature very well. And on the right of screen, you can see good multifidus muscles at the top. Middle one shows some fatty deposits, and the lower one quite extensive fatty deposits. within the multifidus muscle. And it does vary a little bit by level, and it's natural to have a little bit more fat down there at L4-5, and in particular L5S1, even in very fit patients. So the multifidus muscle is the primary stabilizer of the lumbar spine, and it is basically working all the time in an involuntary way to maintain stability. So it's there working away in the background, keeping our spine stable effectively for us, or one of the stabilizers. What we believe in a number of patients is that chronic lower back pain is actually caused by functional instability. And that doesn't mean like a spondy translating. It just means that there's this micro instability where there is an inadequate control of the whole unit. And it is a controversial concept. So what happens with other treatments? It's something I've done a lot in the past for chronic lower back pain, certainly been popular in certain parts of Australia, Europe, and really pain clinics all over the world, is facet denervation. And I used to do a lot of these, and I've backed off quite a bit recently, particularly in younger patients, due to findings of our own research, which has been presented but not published yet, where we did magnetic resonance imaging of the lumbar paraspinal muscles after successful bilateral facet joint denervation. So we took patients who'd had success with the facet denervation treatment and MRI'd them afterwards. So these are patients who had an improvement in their VAS of 50% and were happy with the result of the procedure. But we did find that there was a statistically significant decrease in the multifidus at 3 months after this treatment. So burning the medial branch of the primary posterior rami can affect your multifidus. And whilst patients with a true facet arthropathy can get relief from the denervation procedure, maybe we are doing more damage in the long term. And perhaps that is why you see this technique, when it's repeated, which it is in many patients, often losing effectiveness with the passage of time. So this is the Reactivate device. It's effectively a battery and wire device, and the battery is placed subcutaneously in a pocket, either below or above the iliac crest. Wires are implanted with a sort of loop to allow for movement, and the wires are actually implanted from roughly the L4 spinous process obliquely down and over the L3 transverse process to pick up the medial branch, the primary posterior rami, at the L2-3 level, which is in most people the most robust nerve supply to the multifidus. You do not enter the spinal canal at all when you're doing this. Your lead basically sits just below the intertransverse membrane, and when you're passing needles, they tend to go into the psoas. So it's actually a very, very safe insertion and technique. I've done a few now, so it takes me between 25 and 30 minutes in the standard patient and under sedation, and it can be done as a day case. In the Australian market, just because of billing, etc., for the hospital, patients do tend to stay overnight, but can definitely be done as a day case. So there is a bunch of good data, which is company led on this, but that was quite a significant randomized trial called the Reactivate B trial. And there were 204 patients implanted in that trial. The disease burden is that it's relatively severe. So you can see on the chart on the right where the average patient sat. Basically, they've all failed physical therapy, and they've got an average VAS of around 7 on the lower back scale and severe impairment on ODI. So a lot of them have also failed other therapies. This was a very clean trial, and they excluded previous low back surgery, significant scoliosis or spondylolisthesis. They did include some patients with grade 1, and there were no patients included who had any significant leg pain greater than their back pain. And when you look at how they ran this trial, they basically ran a randomized control trial with an initial sham arm. So implants were performed, but not activated, and an activation arm. And there was initial sham response, as you might expect. But then the results you can see are diverging there fairly early on. And then there was crossover, right, at when the patients were unblinded for those that had the sham treatment initially. And then you can see there that they catch up after the crossover, and there is a progressive long-term improvement. So when you look at the results, about 77% of participants had a 50% VAS reduction, and about 2/3 reported chronic lower back pain resolution. 2/3 also had a reduction in ODI of greater than 20 points, which is quite significant. And look, the durability of results at 3 years is the important thing. And I think this is unlike a spinal cord stimulator or peripheral neuromodulator, where you get relief by effectively distracting the way the brain gets those pain signals. And it can be effective almost straight away in those cases. This takes time to work because it is restorative neuromodulation. So we've looked at some of my cases, and this data is a little bit old. We've done a few more cases now, but these are also cases of my colleague, Dr. Yao, through our clinic in Adelaide, South Australia. This was some data from last year, but we had 89 patients implanted at that stage, and we're now well over 100. 47 were male and 42 were female, with a mean age of 57. Pre-op VAS was 6 and ODI 37.8, and our VAS is a little bit lower than that in the Reactivate trial. And it's a private practice setting. And so we do have patients that really want these sort of devices who didn't quite meet the VAS thresholds that have been used in the randomized trial. And so perhaps that's why we're seeing some of the results I'll show. But just wanted to do a quick case study. So one of my early cases, a 26-year-old female who was previously extremely fit and active and was an elite hockey player as a junior. She's a trained physiotherapist and actually a medical device representative, and had disabling lower back pain, limiting driving, and she couldn't even stand in the operating theatre for extended periods of time. Her ODI was 28. She had VAS flares of pain to 8 out of 10, baseline 4 out of 10, and needing intermittent opioids. And this is an MRI, and this is an MRI that the spine surgeon sees, and your heart sinks because there's no major neural compression. It's not isolated single level disease. There's no spondy. So our traditional indications for surgery really are not there. This is 3-level degenerative disc disease with otherwise relatively normal alignment. And this is an incredibly tough problem to treat surgically. This is a bone scan of SPECT showing some dominant uptake at L5S1. But I think doing a fusion or TDR there with the changes above is a terrible idea. This is a standing alignment. This is what we ended up doing. So this is her Reactivate leads placed over the L3 transverse process. She had initial 3 months of ongoing pain, was not better straight away, which is typical with this device, but did show some early improvement. Between 3 and 4 months, she actually improved quite dramatically and was able to return to hockey. When we reviewed her at a year, her ODI was 2, so that's a pretty big improvement, and her VAS back was 0 out of 10. So generally speaking, not all patients have had that result. Of course, we always show our best results in these type of formats, but we have to be honest about what we're seeing. And after 12 months, what we saw was a VAS 50% improvement in about 1/3 or just over 1/3 of patients. A 30% improvement, though, was achieved in 2/3, and getting to a VAS score of less than 3 was achieved in almost half of patients. Greater than 20-point ODI improvement occurred in about 1/5 of patients, and a greater than 10-point in 2/3. So we are seeing improvements across the board. And what we expect to see from the previous industry-sponsored trials is that they will continue to improve over the next few years. So it's not just a sort of set and forget. It is a process of monitoring and follow-up. The biggest result to me with this has been the opioid reduction. So what we're seeing is that although only 36% of patients improve their VAS by less than 50%, over 1/3 of patients are off opioids altogether, and over 50% were on some form of opioid to start with. In Australia, I wouldn't say we have a crisis, but we've still got a lot of patients that are taking some form of low-level opioid medication to help with this. And we have seen drastic reductions in those. So a lot of patients improve by 2.5 points on their VAS, but they're also off their opioids. And that to me is a big win for a device that's fairly minimally invasive to implant. We've been looking at discectomy and laminectomy, and this is a fully funded, ethically approved study that we started. And I just want to say a few words on this because we've stopped it. And what we tried to do was recruit patients that have had discectomy or laminectomy. We had very specific recruitment goals and inclusion and exclusion criteria. And these were our endpoints, all the usual all the usual prospective study endpoints. What we found with this very rigorous criteria was that we were not getting many candidates for the actual study. Now, we have done a number of implants in post-laminectomy discectomy patients, and I'm very happy to fill people in on that. That's upcoming meeting abstracts. But a lot of the patients didn't quite meet this criteria. And the biggest thing that we found with post-laminectomy and discectomy patients that complained of ongoing back pain was that it was perhaps not severe enough for them to be accepting of a battery and wire-based device. And I'm always honest with patients, this battery, it's not that slimline, it's kind of bulky as this first generation, and it'll get better with time. We've had maybe 5 or so revisions of the pocket and 1 infection in my cohort. And so the battery pocket can need redoing at times. And that can be an issue for some people. So in the end, we haven't been able to recruit enough patients for this trial. And whilst I will now do this device on post-discectomy and laminectomy patients, it's not within a trial setting. I have been expanding indications for the device. This is a patient with scoliosis that wouldn't have met the initial trial criteria. They've also got a spondylolisthesis and a bit of lateral listhesis at L3-4. Very subtle spondy on the lying scans. It's more of a lateral and rotational issue, and really didn't want to have major corrective deformity surgery. Very active male. We thought we'd try the reactivate. No major leg symptoms at present, and after only 3 months of therapy, the patient is off opioids and almost pain-free. So he's done very well. Now, I haven't had this result in every patient I've implanted with scoliosis. So to me, it's been 50-50, the success rate. But if you're looking at T9 to pelvis versus this, is it worth a go? And that's a question that remains to be answered. And that leads us on to the next type of problem. When you look at a patient like this with multiple prior surgeries, TLIF and decompressions and positive sagittal balance, and in the end, she got T10 to the pelvis in my hands and is actually doing very well. But can we use the device to make these patients stronger before surgery and prevent complications like PJK? And that work is going on at the moment in the United States, I understand. Also, in more straightforward cases, can we prevent adjacent segment degeneration? This is a patient with fairly pristine disc T12L1, L1, L2, and L2-3, L3-4, a little bit of change, dominant change 4-5-5-1, and that was causing the neural compression. I addressed that with the ALIF, good alignment, perk screws as well. Within 12 months, the disc above is gone, and we're extending the fusion. And then the question is, can we actually help this not happen with a device like the Reactivate? And I think, again, time will tell, but that's a potential for expanding the indications at present. So with that, I'd like to thank you for your attention. Happy to answer any questions, and you're more than welcome to visit me anytime here in South Australia, and we can take you through what we do. Thanks again.
Hi, everyone. Thanks for joining. Sorry we had to record that. As I said, we had a little bit of last-minute faculty unavailability and had a talk sort of ready to go, but had to do a recording today, so couldn't do too many live questions. We've answered a few in the chat box already. Look, I think there is still a lot of work to be done on the exact indications for this device. Exactly how it works, I think, remains to be fully determined. There is definitely effect on the strength of the multifidus with this device. One of the disadvantages that I haven't mentioned in the presentation that I want to mention now is it is still not MRI approved. So it is an MRI compatible device to 1.5T, or designed to be, but it is not yet MRI approved. And so we're waiting on that. And when we get that, we can hopefully do MRIs of patients, actually look at their multifidus and see if things are improving or not. I think there is also an effect from just stimulation of that medial branch in terms of reducing pain. And, you know, we know from some types of radiofrequency procedures, such as pulsed RF, that just stimulation of a nerve and nerve branch can actually provide substantial relief for some patients, not all, of course. So there may also be an actual a neuromodulation effect in terms of pain relief, in addition to the restoration of function of the muscles, so the restorative neuromodulation component. Hopefully be able to get some other experts in this area on with a bit more notice, because I do think it is worth discussion, and we should be involving discussions regarding pain techniques and our pain physicians in this type of meeting. If there aren't any more questions on the chat box, I will jump. But we'll have a bit of a shorter session today. I'll jump off if there are no further questions, and I don't think any of the other faculty are with me at the moment. We'll put up on Twitter, on the Virtual Spine channel, and LinkedIn the procedures for next week, what's going to happen, and I hope to be able to see you again soon. If you do have any questions about the device, want any more information, just message me on LinkedIn or Twitter, and I'm happy to help out. We can put you in contact with people that can train you and go from there. Thank you.